Okay, so we're going to discuss the Jones criteria in helping make the diagnosis of acute rheumatic fever. These criteria say that at least two major manifestations be present, or one major and two minor. Now, conveniently, the words Jones criteria can be used as a mnemonic, the J standing for joints. This is a migratory polyarthritis affecting the large joints. The O can either stand for obvious because the heart is the obvious organ that we're talking about, or it can be thought of as looking like a heart, causes a pancarditis and numerous other sequelae. The N stands for subcutaneous nodules, and we'll talk about this in just a moment. The E is a very distinctive rash called erythema marginatum, also known as erythema annulare because of its ring shape. And finally, the S is for Sydenham's chorea, which is a neurologic sequelae. Now, the minor criteria, we use the word criteria, but we throw out the C, we throw out the R. And we begin with the letter I, which stands for inflammatory cells or leukocytosis. Sometimes this is left out of the minor criteria, but I decided to just include it to let you know. The T is for temperature, fever. E is ESR and CRP, the acute phase reactants. The R is for a raised or a prolonged PR interval. And then the I is itself, so any previous history of rheumatic fever is a minor criteria. And then finally, arthralgias, which are just joint pains. Again, you need two major manifestations or one major and two minor in making the diagnosis. So looking at the major manifestations a little more closely, the migratory polyarthritis usually starts at the legs and works its way upwards. It affects the large joints, often leaving them red, hot, and swollen. NSAIDs and aspirin readily relieve the pain. There are many cardiac manifestations. The most common lasting sequela is mitral valve damage due to scarring. Symptoms may be very subtle, such as only chest discomfort. Cardiomegaly is the most common radiologic manifestation of carditis. The subcutaneous nodules tend to be firm and painless, usually over bony processes, an average of about 3 to 4, but they range from maybe 2 to 12, and they only last a couple of weeks. The erythema marginatum is a non-pruritic rash that spreads outward. It usually only occurs if there is carditis. And then Sydenham's chorea, also known as St. Vitus dance. Now, by the time people present with rheumatic fever, throat cultures are negative 75% of the time, but streptococcal antibodies are more useful at that time because they reach their peak titer level at that time, and they also indicate a true infection versus just transient carriage.
Just to go over some of the specific findings in acute rheumatic fever, because we don't get to see it very often. First is the rash, erythema marginatum, which is a type of annular erythema. It is the characteristic rash associated with acute rheumatic fever, but fairly uncommon, occurring in about 10% of first attacks of acute rheumatic fever in children, and is very uncommon in adults. The rash, when present, is found on the trunk and upper arms and legs, but almost never on the face. It appears as pink or red macules or papules, which spread outwards in a circular shape, and as the lesions advance, the edges become raised and red and the center clears. The lesions are not itchy or painful and sometimes go unnoticed by the patient. They can fade and reappear within hours and may persist intermittently for weeks to months. Next are the subcutaneous nodules. These are actually very uncommon findings in acute rheumatic fever, occurring in less than 2% of the patients. They're painless, found usually over joints, elbows, knees, ankles, knuckles, sometimes the back of the scalp and on the vertebrae. The nodules are firm, round, mobile, and range from about 0.5 to 2 centimeters in size. Nodules are usually found only when severe carditis is present and resolve within about 1 month. Carditis is the most serious manifestation of acute rheumatic fever and is characterized by valvular heart disease, although it's described as a pancarditis, the mitral valve being the most common valve involved. and the aortic valve also commonly being involved. Right-sided heart valves are rarely involved. Initially, the lesion is a thickened valve with some vegetations that form. And in the acute phase, patients present with a clinical picture of tachycardia, congestive heart failure, arrhythmias, pericardial friction rub, apical systolic murmur of mitral regurgitation, or basilar diastolic murmur of aortic regurg. Also have cardiomegaly on chest x-ray. On ultrasound images, you'll generally see a thickened mitral valve, as you do in this image, with dilated left atrium, sometimes thrombus formation. In chronic rheumatic fever, you eventually develop obstructive lesion, as you can see from this mitral valve. The myocarditis associated with acute rheumatic fever is characterized the pathognomonic finding of Aschoff bodies, which are large, elongated cells with large nuclei, some multinucleate. Arthritis is the most common manifestation in acute rheumatic fever, occurring in somewhere between 60 and 80% of patients. It usually affects peripheral large joints, the knees, ankles, wrists, and rarely involves the smaller joints like the toes. It is an asymmetrical, migratory, very painful polyarthritis, and usually resolves within about 2 or 3 weeks. The following are examples of Sydenham's chorea, or St. Vitus's dance. It is characterized by involuntary muscle movements, and the first clip is a more acute example, and the second clip is during the recovery period. The chorea does usually resolve over a period of months to years.
Je merkt wel dat je dit doet? Dat je nu helemaal weg bent.
Turn around. Fantastic. How was that? Pretty good, I'd say. She's not too drunk. Oh yes, she is. She's drunk. Oh, she's everywhere. Quick, call the police. Oh no.
This is just a slide demonstrating the time course of the clinical manifestations of acute rheumatic fever to give you some idea, with polyarthritis usually occurring early on, as well as carditis, but then improving. The chorea and subcutaneous nodules occur later on, but last much longer time.